There we go. Good evening and welcome to our Waltham Public Library program, Alzheimer's and Dementia, the latest in research. My name is Deborah Hoffman and I organize programs and events for the library. Thanks for tuning in. Before we start, I want to let you know how the evening will go. Our speaker will do a 30-minute presentation and then she'll field questions. To ask questions via the chat function, use a Google account to sign into YouTube. Feel free to write your questions at any time, and then I'll read them at the end of the presentation. Liz McCarthy is the Health Systems Director for the New England region of the Alzheimer's Association. She also serves as one of 2 research champions in the region. Liz has been with the association for almost 6 years. Prior to that, she had a long career in medical device sales and marketing. A resident of Waltham for 20 years, Liz lives in Warrendale with her husband and 2 teenage sons and considers the library one of Waltham's treasures. Thank you so much for being with us tonight, Liz McCarthy.
Thanks so much, Deborah. It's great to be with you. I'm going to go ahead and share my screen and we'll get started.
Great, I can see it.
Terrific. So as Deborah said, I am the Health Systems Director for the Alzheimer's Association. That work takes me to all 6 New England states. And in my role as the research champion, I am really fortunate to be able to work with our in-house team of scientists and hear from them about the latest in research and then do this presentation when I have an opportunity. So a little bit about the Alzheimer's Association. We're the largest worldwide voluntary health organization dedicated to Alzheimer's care, support, and research. And our mission is to lead the way to end Alzheimer's and all other forms of dementia. And we do that by accelerating global research, looking at risk reduction, early detection, and maximizing quality care. People often ask about this, our icon, our little symbol. It's supposed to represent the brain and science where they come together. So that's that. Today, we'll talk about the landscape of Alzheimer's and dementia science, about the highlights in early detection and diagnosis, some of the latest advances in clinical trials, treatments, and lifestyle interventions, and then we'll discuss how you can get involved, including an app you can download for your phone. Every year in the April timeframe, the Alzheimer's Association releases facts and figures. In 2021, we focused on a bit on the COVID-19 pandemic, which really took a terrible toll on seniors, people living in long-term care settings, as you've heard, and Alzheimer's and dementia deaths increased 16% during the COVID-19 pandemic. The other focus of this year's facts and figures was looking at discrimination and how it's a barrier to Alzheimer's and dementia care. And you can see that populations of Black Americans, Native Americans, Asian Americans, and Hispanic Americans all reported discrimination when seeking healthcare for cognitive impairment or memory loss. So digging into that a little more deeply, there are gender, racial, and ethnic disparities in Alzheimer's prevalence and in research and clinical trials. Almost 2/3 of Americans with Alzheimer's disease are women. And the kind of old school thought was, well, women live longer than men do, and age is the #1 risk factor for Alzheimer's disease, so that's it. Well, that wouldn't explain that type of how big that gap is, that 2/3 are women. So there's a lot of research really going on right now looking into the number of children a woman might have, or if she has children, breastfeeding or not breastfeeding, the age she was at pregnancy, menopause, all of those things might be factors. Some might be neuroprotective, and some may hinder the neuroprotective aspects of the brain. Older Black and Hispanic Americans are much more likely to have Alzheimer's disease than their white counterparts. Black Americans are 2 times as likely, and Hispanics about 1.5 times as likely. So there's a lot of research into why that is going on. And as I mentioned, ethno-racial groups have been historically underrepresented in clinical studies, and we're really making a big push to recruit them into clinical studies so that we can better see what's happening and why there are these disparities in prevalence. Oops. Apologies. So when we talk about the word dementia is actually a word that describes a collection of symptoms. So the symptoms of dementia include cognitive decline, behavioral and psychological symptoms. But dementia itself is not a disease. It's a symptom of a disease like Alzheimer's disease. And in fact, Alzheimer's disease makes up about 60 to 80% of all-cause dementia. Vascular dementia, Lewy body dementia, and frontotemporal lobe dementia are all different types of dementia. And many people present with more than one of these neuropathologies. So, for example, people may have vascular dementia along with Alzheimer's, or Lewy bodies along with either vascular or Alzheimer's disease. Cognitive impairment is a continuum, and mild cognitive impairment is a known risk factor for dementia. So when we start out, we are cognitively unimpaired. We move through mild cognitive impairment. Mild cognitive impairment is a known risk factor for dementia, but not everyone who experiences mild cognitive impairment goes on to develop dementia. So there's a lot of push right now to say, what we've got somebody who is symptomatic, but their impairment does not impact their activities of daily living. And to keep them there, that is, how do we prevent it from progressing to mild dementia? And then there are people who have mild cognitive impairment who also never go on to develop dementia. And we need to study them to see how things might go and why that is. What is it about their brain that's keeping them from moving into dementia? So this slide is a little busy, but I'll break it down for you. The hallmarks of Alzheimer's disease, this is really getting into the neuropathology of it. There are 2 types of proteins that are naturally occurring, but they both go a little rogue in Alzheimer's disease. The first one of these is called beta amyloid. And the beta amyloid is, it's a sticky protein, and it starts forming clumps outside of the neurons. And then these clumps will prevent the signals from crossing from neuron to neuron. So that's what the beta amyloid does outside of the cell. At the same time, inside the cell, there is another protein called hyperphosphorylated tau. And the hyperphosphorylated tau actually starts to destroy the cell itself by breaking down the scaffolding of the cell. So you've got beta amyloid preventing signals from crossing neuron to neuron, and then you have hyperphosphorylated tau, which is causing the neurons to just kind of collapse on themselves, and that leads to the death of the cell. So when you look over here at the brain on the right, you've got on the left side of the brain, this is a normal brain. And on the right side, this is a brain with advanced Alzheimer's disease. So there is significant tissue death, right? That's occurring. In fact, an adult brain weighs about 3 pounds. And in advanced Alzheimer's, the brain weighs about 1 pound. So that's all the cells that are dying. So what may impact risk? There are non-modifiable risk factors, things that can't be changed. And no matter how much I would like to, I can't change my age. We also can't change our genetics or our race or ethnicity. However, there are things that we can change and things that affect our overall risk. And those are things like environmental and lifestyle factors, cardiovascular health, physical activity, diet, sleep, social and cognitive engagement, education, and traumatic brain injury. And my younger son, I have a 15-year-old who will tell you that I try to make him wear his bicycle helmet all the time, even if nobody else wears bicycle helmet, but it's very important. But all of these things may play a factor, and these are the things that you can do what's good for you below the neck is good for you above the neck. So if we have good health overall, our brain will also stay healthy. Just really briefly, a little bit about sleep. There's been a bunch of recent research into that, and it seems that the sweet spot for reducing the risk of Alzheimer's disease and dementia is about 7 to 9 hours of sleep per night. So if you're getting less than that or more than that, we should try to fine tune it and get in that 7 to 9 hours per night area. So we'll talk a little bit about available therapies. This gentleman here on the far left is Dr. Alois Alzheimer. He was a German researcher who gave the first description of the disease back in 1906. But he had a patient whose name was August. August died of the disease, and then he was able to perform an autopsy and look at her brain, and really was the first person to describe those plaques and tangles that we just talked about in the other slide. It took 90 years before we had any kind of a treatment. And donepezil, which is the brand name is Aricept, came out in 1996. Donepezil was followed by rivastigmine, galantamine, memantine, and then they combined memantine with donepezil. It's a drug called Namzaric that is frequently used now. But all that any of these do is treat symptoms. So we already talked about how we have in dementia, we have fewer brain cells. What these drugs do is they increase the signals that are going across each brain cell. So we have fewer cells, but we're trying to make the ones that we still have work a little harder. So that's what they do. And they can be quite helpful, but it's time limited. They're not going to do anything to certainly not reverse, but also not to slow the progression of the disease. This year, you may have heard in June, the FDA approved a drug called aducanumab. The brand name is Aduhelm. It's manufactured by Biogen in Cambridge. And this is the first disease-modifying treatment that we have. And that's why it was so exciting and is so exciting. The MAB on the end of aducanumab means that it's a monoclonal antibody, that they've been in the news a lot with some COVID-19 treatments, but this one really targets the beta amyloid. And getting that first one across the starting line is now going to open up for a lot of other monoclonal antibodies that are currently in clinical trials to come out. So we'll look for those. So behind the various research efforts that fueled by the Alzheimer's Association, science is always advancing, and not just in one area, but really research occurs on every front line across disciplines, biochemistry, pharmacology, devices, neuromodulation, all kinds of things, and milestones are being achieved. So at any given moment, research, learning, and discoveries are happening. the Alzheimer's Association, I'm very proud of this work. We are the largest nonprofit funder of Alzheimer's and dementia research in the world. We're behind the US government and the Chinese government fund more than we do, but other than that, it's us. So we have $250 million currently active in 730,000 projects in 39 countries. And just to bring it local for a second, because we are here in what many people refer to as the Mecca of research and medicine, we have $19 million currently invested in active research in Massachusetts. So something else I'm very, very proud of. And we advocate. Alzheimer's disease is one of the very few things these days that is nonpartisan. Nobody likes Alzheimer's disease. So we definitely do a lot of lobbying. We advocate to get the government to put more funding into research for Alzheimer's disease. And you can see that we've been quite successful. Back in 2011, it was under $500 million, and now we're at 3.4 billion is the target for 2022. So all of this is going to NIH and NIA funded studies. It's a really exciting time in research, and I'll share a little bit about what's happening now. Biomarkers are really changing the game, and I'll unpack this slide a little bit. About 8 years ago, a Alzheimer's Association funded study at the University of Pittsburgh found a dye, right? A dye that will link to the beta amyloid. And when it links to the beta amyloid, when you do an image called a PET scan, it lights up red. So if you see red here, all that is showing where there's beta amyloid in this person's brain. So that was the first time we were able to make a definitive diagnosis without having to do an autopsy. Prior to having this dye for the brain that links to the beta amyloid, you were diagnosed based on your symptoms and your presentation. But now we can actually do a PET scan to be very definitive about the study. What we'd like to get to is to have a blood-based biomarker, right? So when you go to the doctor, you get your blood drawn and they can tell you your cholesterol level and all kinds of other things. We would love to have that to say whether there's anything going on neurocognitively that we could see in the bloodstream. There are other things going on. This is a picture of an eye. That's an eye. So here is your pupil. And researchers are looking at using light modulation and as well as looking through the pupil, and they're able somehow, I don't know how, but to see if there is, it's something about the uptake or the speed of which the blood is passing through the artery that goes right behind the retina. And that can be perhaps a symptom or an indicator that there's some dementia going on. And then finally, there's a lot of genetic research going on. This is your good old double helix DNA and looking at your DNA as a biomarker as well. So it's important to modernize the diagnosis, as we were talking about mild cognitive impairment earlier, and I have another slide in a little bit, we'll talk about it. But these biomarkers are building up for as many as 20 years before the symptoms appear. So what I hope will happen is, for example, at age 30, women go and they get their first mammogram, right? And then they have one every 5 years after that. And anybody, once you hit the age of 50, you're supposed to get a colonoscopy. So this would perhaps say, hey, at the age of X, we're going to do a test, whether it's a blood test or an eye test or some other sort of test to see if there are any of these biomarkers that may be indicative of Alzheimer's disease. So again, we're making a lot of advances toward effective treatments and interventions. And I talked about aducanumab a few slides ago. It's important to note that there are all kinds of shots on goal, right? So there are 129 drugs and devices currently in phase 1 trials, 191 in phase 2, and 62 drugs and devices that are all the way in phase 3. So and this was as of April 2021. It could have even changed since then, but definitely they're making all kinds of shots on goal and finding which of these drugs and devices may work. How to get involved in research. One of the great ways to do it is with our Trial Match program. Trial Match, it's a matching service for clinical trials. If you go on to the website alz.org/trial match, they'll have you fill out a little bit of background information, and then it tells you what studies in your area might be looking for candidates like you. Some of them need asymptomatic people, some of them need younger people, some of them need people who have a history of the disease in their family. There are all kinds. As it says, there are more than 300 clinical studies at more than 500 locations. And Trial Match has over 350,000 users. So some of the treatments currently being tested are looking at changing both the cognitive part of the disease progression as well as the behavioral and psychological part of the disease. So when we talk about cognition, we're talking about memory, learning, thinking, and planning. And then behavioral and psychological symptoms are the things that are most difficult for the family caregivers of people with Alzheimer's disease. And they include things like depression and anxiety, delusions, hallucinations, apathy, agitation, and sleep disturbances. And increasing the success of the family caregiver will definitely improve the quality of life that the person with dementia receives. But when you're getting woken every morning at 3 a.m. because your loved one thinks that they have to get up to go to work, even though they haven't worked for 20 years, or they're having hallucinations or delusions, it can be really difficult to work with. So they're definitely looking at pharmacology that might be able to help some of these symptoms. The Alzheimer's Association is working with a major funder from the California area. Her name is Mikey Hogue. And she is a very wealthy person who knows a lot of very wealthy people and gets them all to put their money behind some really promising research. And this is called the Part the Cloud Translational Research Program. And in fact, they just raised $33 million that they'll be really funneling into these most promising new therapies. And some of the most promising new therapies include looking at the mitochondria, which is sort of like the engine for every cell in your body. Looking at clearance. So I was talking about all the beta amyloid and the tau, and they cause the nerve cells to die. But how can we get the trash out of the brain that would decrease the neuroinflammation and keep what's still there healthy? And then looking at vascular contributions. I can tell you that in 2020, in November of 2020, we had two Part the Cloud Award recipients here in Massachusetts. And our typical awards are usually around $150,000 over 3 years, something like that. The Part the Cloud Awards are usually in the millions of dollars. So there were two organizations that got $2 million each from the Part the Cloud because their research is the most promising, and we want to really springboard that to give it an opportunity. So this is going back a little bit to the lifestyle factors, but In 2018, the Sprint Mind study was the first study to demonstrate how that we can reduce new cases of cognitive impairment. And the way that they did this was by addressing blood pressure. So they put candidates into an aggressive blood pressure management program, and then there were controls who were kept in the regular blood pressure maintenance program. So the people who were in the aggressive program, where they really lowered that top number, which is the systolic number. If you 120 over 80 is the average blood pressure. So these people who had high blood pressure, they were treated so that their top number stayed at 130 or below. Usual treatment is 140 or below for the systolic number in the management of hypertension. And it showed that by keeping this reduction down, they decreased the risk of going on to develop dementia and mild cognitive impairment. So really groundbreaking and showing again that kind of vasculature relationship with the brain. So research suggests that combining multiple healthy factors probably has the greatest impact. And so some interventions that may reduce risk, we already talked about, are physical activity. This lovely lady in pink is doing a nice tree pose outside, cognitive and social stimulation, and a healthy diet. Another study that is going on and is funded by the Alzheimer's Association is the US Pointer study. And it is a 2-year multi-center randomized clinical trial that includes self-guided and structured lifestyle groups. So that is, one group is kind of told, go it yourself, but this is what you should do. And the other one has a coach calling in to make sure that they're doing what they're supposed to be. We're recruiting 2,000 participants at 5 US sites, looking for people at the ages of 60 to 79 years with suboptimal lifestyles. And we were very excited when one of the sites is here in New England. It's at Butler Hospital in Providence, Rhode Island. The National Institutes on Aging is supporting a bunch of ancillary pointer studies looking at neuroimaging and sleep, the microbiome, which is the gut-brain axis, and then neurovascular contributions. And US Pointer is not alone. In fact, the whole thing got started in Finland, which is this purple crescent here. In Finland, they started the Finnish geriatric study that was, again, a lifestyle modification program. And they found that they were able to reduce the incidence of mild cognitive impairment and dementia, and to keep people with mild cognitive impairment from progressing to dementia. So you can see they're doing things all over the world now that are similar, and hopefully we'll be able to get some really great advice on our lifestyles soon. So I keep on talking about mild cognitive impairment and preventing mild cognitive impairment, or preventing that mild cognitive impairment from progressing to dementia. And what's the deal behind that? Well, if we develop a treatment by 2025 that delays the onset of Alzheimer's by just 5 years, that means by 2050, almost 6 million people who would have been expected to get Alzheimer's disease would not get the disease. So it's really kind of mind-boggling. And I told you I'd give you a tool that you could download on your phone. You can download the Alzheimer's Association Science Hub app from wherever you get your apps. There is a lot of, obviously, Alzheimer's written content, but there's also a tab that is the news tab, and that just has feeds from Reuters and the AP. So just all the general news you can find there as well. So in summary, the Alzheimer's Association is the global leader for Alzheimer's and dementia science. And I hope you saw that this is a really exciting time in research with all those shots on goal and all the different things that scientists are looking at. and that research gives us hope. And our vision is a world without Alzheimer's disease. And now I will stop sharing, and I'd be happy to answer questions.
Thank you so much for that, Liz. There was just so much information that you presented so clearly, and it's clear that there's a lot happening in Alzheimer's research right now, which is exciting. We do have questions, so I think we should get to those. What really causes Alzheimer's, and is an ethnicity more likely to get it than others? Is there a more holistic treatment and cure, and how early can a person have it? So that's really 3 questions.
Wow. Okay. So I'll start with the first one, which can you read the first part of it again? I'm sorry, Deborah.
Yes. What really causes Alzheimer's, and is an ethnicity more likely to get it than others?
Yep. So what causes Alzheimer's is basically the death of those brain cells. So whether it's the amyloid plaques, the hyperphosphorylated tau, those brain cells are dying, and that is what causes the symptoms that make up Alzheimer's disease and other dementias. So it's the neuropathology that your nerve cells are dying, and you can't function without them, or as you had previously, right? And then different ethnicities. Well, we talked about racial disparities, racial differences. There is an area of research that's looking at ethnicities. One of the most famous is an extended family in the country Colombia. And this family, it's been on the general news. I think there was an episode on 60 Minutes, and they're often in the news. But this extended family has a genetic flaw that causes people in the family to develop Alzheimer's disease when they're in their 30s. And the family has been so astoundingly generous with the research community, allowing researchers to look at their DNA, and thinking about it as an individual. You're going to get this study done, and they're going to tell you if you have the mutation on your gene. It's just such an incredible gift that they've given. So that's a familial strain. As far as ethnicity goes, I'd have to look at it a little bit more closely. I apologize that I can't answer that off the top of my head.
So the other questions, is there a more holistic treatment and cure?
The most holistic treatment, again, is the modifiable lifestyle factors. So we go back to what's good for you below the neck is good for you above the neck. That's not a treatment, but certainly could be a prevention. As far as treatment goes, as I mentioned, there really is only one treatment right now, and that is the aducanumab drug. The Alzheimer's Association promotes person-centered dementia care, which is really understanding the reasons behind the behaviors of Alzheimer's disease, and getting involved with the patient. If they're fidgeting, why is it that they're fidgeting? Are they in pain? Are they thirsty? Are they hungry? Are they frightened? And just being with them and putting them at the center of their care. That's something that we strongly advocate for. But again, there is only one treatment now, but there's a lot you can do to prevent getting it. And then the third question was
how early can a person have it?
Yeah. So I just talked about the family in Colombia with the genetic mutation. So they get it in their 30s and 40s. Very it's rare, but it's not. I think that we're getting a lot better at diagnosing as well. But there is a younger onset Alzheimer's disease, and I guess sadly or happily, I've worked with many of these wonderful, incredible people during my time at the Alzheimer's Association, and it's quite devastating. But I have to say that they're all happy to find out that they're not going crazy, that it's something that's happening with them. And they have, again, talk about a group of superheroes. They've been so generous with their time and participating in clinical trials and advocating for more money for research, just an incredible group of people. It's unusual, but people can get it as early as their 30s and 40s, even people who are not from that Colombian family with the genetic mutation. But that is very unusual.
Okay. My brother-in-law's father died of Alzheimer's, and his brother recently died of the same. So is there a genetic link?
Yeah, there is. There's a gene. It's the APOE4 gene. And people who have this gene do have a higher likelihood of getting Alzheimer's disease. However, there are people who have the gene who don't develop Alzheimer's. That's another area of study. When you hear about familial cases, and I lost my mom to frontotemporal lobe dementia, so I'm very cognizant of this. When you have to also look, though, at what are the other perhaps modifiable risk factors. So that in this particular case, if the father and the son both had hypertension, that would rate that perhaps that might have made them more likely, or they both had poor diet. If they both, and I'm not saying, forgive me if I sound like I'm criticizing, but that is if there were other underlying factors within the family that would have made it more likely to have Alzheimer's disease, then that could have happened even without having that allele, the APOE4.
Families of Alzheimer's patients suffer along with them, perhaps more. Does the Alzheimer's Association also research how caregivers can best help the sufferers as disease advances?
That's a great question. Thanks for asking it. Absolutely. So we definitely do research with caregivers for people with dementia. And in addition, we try to take care of them. We have support groups, we have education programs. In life pre-COVID and hopefully coming back soon, we used to have what was called an ALZ meetup, where dyads, that care partners and a person with dementia, would come and perhaps enjoy the Museum of Science or the Art Museum, or go to the Tower Hill Botanic Garden, or even they would go attend plays at the ART, or sometimes just meet at Starbucks and kind of have a moderated little discussion. But certainly, and all of our programming for people living with dementia and their loved ones is at no charge. So I would definitely encourage you to check out our website, alz.org. As far as the research goes, a lot of it is more focused on what supports make a difference, have an impact on the life of a caregiver. And so there is a lot of research going on with that. At the Massachusetts, New Hampshire chapter, in fact, we have a program called Dementia Care Coordination, and we are in the at the tail end, we got a grant from the Merck Foundation to that allowed us to hire a consulting firm to look at its impact, and we will soon have final results. We're hoping to get it published, yeah, and then present it hopefully at the Alzheimer's Association International Conference next year. So it's more looking at how those programs, which are most helpful for caregivers, how do you delay nursing home admission, those kinds of things.
And are all of your programs online now, or do you still have some in person?
Right now, everything is, I want to say, I think some of the support groups have started coming back as hybrid, because people definitely found it, sometimes this is easier, especially if you have a loved one with dementia in your house. But some of them are moving back to hybrid. We still do require masks. Everyone has to wear a mask for any Alzheimer's Association event.
This is such an informative, so informative. Can you speak a bit more about mild cognitive impairment and how to recognize it? How can we tell it apart from the regular woes of aging, like forgetfulness and confusion? And I would guess that many of us watching this are wondering the same thing.
Yeah, that's also a great question. So when the key thought behind this is, when does it begin to impact your daily life? So when is it? So I've put my car keys in the linen closet one day, and I had no idea where my car keys were, and I'm running around. I finally was able to retrace my steps and find the car keys. And my husband asked me, should I be worried? But that is, I was doing 800 things and I put my car keys in the linen closet. It's not as if I'm always putting car keys in the linen closet, or getting lost on my way home from work, or I'm unable to retrace my steps. I'm unable to pay my bills on time. That's often a big clue. Mm-hmm. Having difficulty with banking, all of a sudden, like overdraft fees or something that you've never had before, and all of a sudden they start appearing. So those are all signs that something isn't normal, something's not quite right. But forgetting where I parked the car, I mean, all the time, and yeah, keys and where's my purse and those types of things. That's just normal. There is on alz.org and sometimes there are programs, but it's called Know the 10 Signs, and that can walk you through it as well.
Great. That's a helpful resource. Thank you.
Yeah.
So I have a question for you. I read about research from the Florida State University College of Medicine, and it found that changes in the brain associated with Alzheimer's disease are often visible early on in individuals with personality traits associated with neuroticism and conscientiousness, or neuroticism or conscientiousness. And I just thought that was a little weird. And I just wondered if you could talk about that.
Yeah, well, it's fascinating. And I'll let everybody know that Deborah did share the article with me. So I was able, because I hadn't heard about it either. I think that it definitely fits in with what we're saying about this disease starts, as much as 20 years prior to showing symptoms, and that there are neurological makeups, like a neurological fingerprint, that might make someone more likely than someone else. But the conscientiousness part of it. So the people who are more conscientious are less likely to progress. And a lot of that behavior is what we recommend. It's socializing and being engaged and, just kind of enjoying life, right? And doing those things. Another thing that it made me think of is that among the top 5 diagnoses that physicians include when they do a cognitive assessment or care planning, among the top 5 is depression. And that's always there. So there's definitely a link between psychological makeup and then your actual neuropathology.
Okay. Here's another question from the audience. What's the difference between dementia and Alzheimer's? And you touched on that a little early on, but maybe you could go into that more.
Sure, of course. So Alzheimer's is a disease that causes symptoms that make up dementia. So if you think about it, if I have a cold, right? So my symptoms are, I have a cough and I might have a fever and I have a runny nose. So that's, so dementia, it's actually an old term. We should, it's sadly, I think, too locked into everything now. It's not going to go away, but it's this collection of symptoms that you have memory loss, you have some behavioral changes, you might have word retrieval issues. That was a major characteristic of my mom. Like I mentioned, you may be withdrawn, show symptoms of depression. So those are all these symptoms, but they're being caused by the death of the neurons in the brain. So something very physical is happening to cause these changes.
But it's true that you can have dementia, but not have Alzheimer's. Is that right?
So the dementia would be being caused by another form. So either Lewy body, dementia with Lewy body's frontotemporal lobe, vascular dementia. Those are the 4 main ones. There are a couple others, but yeah.
Some Alzheimer treatment deals with NMDA receptors. There have been recent breakthroughs with ketamine and other brain illnesses. Is there any research looking into ketamine as a drug to help with symptoms?
Yes, there is. And there's probably more than one study going on, but at least one is in phase 3. So definitely looking at that for sure.
Do you know what ketamine is? Because I don't.
The person who asked the question might be, but they're talking about the NMDA receptors. So it's, let me just get a quick, I want to give a good definition without, yeah, okay. So it was initially used for treating depression. So it's a drug that was initially used for treating depression. They're actually big pharma is looking at a lot of these older drugs and molecules that they have and trying to use them in novel ways. So the problem with ketamine is that it makes you go into a trance-like state. They do use it sometimes in anesthesia, like to get you calmed down before they do whatever it is they're going to do. There is definitely exploration into that. And if the person who typed that in seems like they're very knowledgeable, they're using all kinds of words, but you could go to the NIH, what is it? Clinical, let me look it up here. I think it's just clinicaltrials.org. Oh, clinicaltrials.gov, G-O-V. So I can pop it into the chat, but it's just clinicaltrials.gov. And you can then type into the search ketamine, and it will give you all the studies that are doing it.
Okay, I'm just going to copy that to the chat. Great, thank you for that resource. I also want to keep an eye on our time. Would you say that there is an increase in the incidence of Alzheimer's?
I don't think I would say that. I think that we're getting much better at diagnosing it. And I also think that we're getting much better at recognizing that it's not just old age. Mm-hmm. Even, I mean, people who are in their 80s or 90s, if they have dementia, that's a very different situation than someone who doesn't. And we all know those people, right? Like, so, I told you that I lost my mom to frontotemporal lobe dementia. Yeah. My dad died at 91, like 100% here, you know, so it's, I think that we're getting better at diagnosing it, and we're getting better at saying this isn't normal. There's something going on here.
Okay. And I also read about a theory that microbes, specifically the herpes simplex virus, are related to dementia, and I was wondering if you could talk about that at all.
Yeah, so viruses, there's a lot of study into viruses, and if they might lead to a cascade that then ends up presenting as Alzheimer's disease or a different cause of dementia. And one of the areas I know that there's certainly a herpes simplex is one of the viruses because it's so common, mm-hmm. But they're doing tons of studies on COVID right now. I told you about that 16% increase in deaths during COVID-19, of 16% increase. There's also, though, people who didn't have previous neuropathology. They may have been, you know, older in a nursing home, but then they started presenting with cognitive impairment. So what's the link between the virus and the neurology? You know, the global pandemic gave us an awful lot of people that we could look at to see how these viruses, but overall virology is another area where there's tons of research being done to see.
Wow, fascinating stuff.
The virology piece is like mind-blowing. Yeah.
Yeah. It looks like we don't have any more questions from the public. I am also out of questions for you. So I want to thank you again for such an informative presentation. And thank you to everyone who tuned in tonight. Have a good night, and I hope you join us for one of our future programs.